A very good afternoon to one and all of you. Dr. Satanshu, you're not allowed to talk. So, good afternoon to our moderators on dais and dear friends in the audience. And the next few minutes, I'll be talking on clear lens exchange. Now, is it an option or is it not? You have a right to question me on that. But then, how we stand is, today we are doing the best as far as optical biometry is concerned. Yes, we could get better. We have diagnostics right from the dry eye to the OCT to the eye trace, every conceivable evaluation methodologies we have. We have the best of intraocular lenses, premium lenses, toric lenses, the EDOF lenses, trifocals, and enhanced monofocal. So there's everything there. And further to it, if you want to get ultimate, then you have the femtosecond laser cataract surgery. So it has not become vision restorative anymore, but it is vision enhancing. So how do we achieve this? For this, as I earlier alluded to, we need to be accurate in our biometry, because you would have counseled those patients a lot and they have come to you for visual independence for all ranges of vision. You have to be able to choose the right kind of lenses for them. It has to be quality of vision has to be there, that is free of spherical aberrations and chromatic aberrations to what extent you have promised them, the best of surgical techniques, the best of parameters, and of course, even post-operatively, if they are left with some residual surprise, you need to handle it. So it becomes necessary to have all of this, dedicated staff, equipment, technical guidance, to look for all those tiny variables in biometry and choose the best formulae, whether it's for a hyperopic eye, a myopic eye, or a post-refractive surgery eye. Now we have access to IOL masks. I've just taken one example. I'm sure others have good ones. But it has a combination of the swept source OCT and the B-scan biometry. Also has a facility to do the fixation check, so that all of these bring in that level of accuracy. Like how it does is, it uses both the swept source OCT and the B-scan biometry to measure the anterior corneal thickness, the posterior corneal profile. And what it does is, it measures on the anterior corneal profile and interpolates the information of the posterior cornea and gives us total keratometry or the total astigmatism. It has a 3-zone keratometry, and so multiple zones are measured. And this gets incorporated into the Barrett universal formula to become the Barrett TK universal or the Barrett TK toric. The only thing I want to tell you in the slide, which you should remember, is all the other formulas, they have their own mathematical formulae to make their calculations for the posterior corneal astigmatism, though they are not directly measured. So if you put the TK value into those formula, you might end up overcorrecting. That has to be kept in mind. So what you should do is, if a patient comes to reception wanting for a cataract surgery, goes to the optometrist, before the tear film is disturbed, it's mandatory that you do a biometry to understand whether there's a toricity there, and accordingly veer your discussion beyond that. You need to measure for both eyes. Even if the other eye is pseudophakic eye, it gives you a lot of information on the axial length, the keratometry, and if there is a variance between the two eyes, is it asymmetry between two eyes, or is it that the readings need to be repeated? It is also very important that we need to validate measurements. Like if there's a difference in axial length of more than 0.3, a K value of more than 1 diopter, or an IOL power calculation which is more than 1 diopter difference between two eyes, do not assume that the other eye is emmetropic, but you need to check the values. You need to ensure that the technician knows all the measurements, that the green light, that the standard deviation should not be more than 0.2 diopters of 30 micron, the signal to noise ratio should be more than 2. There are a whole lot of things which the axis difference should not be more than 3.5 degrees. So all of these which need to be you should look at those LED points. It should not have a fishtail appearance. They should be crisp points when they are being imaged. Now, in this particular case, you see the dark red shadow there. It could be an artifact. It could be just a Dellen or some kind of atropic pterygium there, but because of which the astigmatism measures differently when you retake the measurement, and then you find that it is far less. It becomes important for you to remember that in the keratometry, like if says that the standard deviation is more than 0.2, then is it dry eye status because of which you're getting errors? If not, you treat the dry eye. If it is not dry eye, you may have to wonder whether there's some keratoconus or there's a PMD. Do a tomography. If the patient has astigmatism, do go on to the toric IOL calculation. In other words, you need to examine right from the ocular surface to the retina. and treat the meibomian gland problem that's there, look at the OCT, whether the patient is fit for premium IOL, and then comes the decision whether it's trifocal or CRVO or EDOF or what you are going to do for these patients. So I'm going to run you through 3 examples: a presbyope, early presbyope, a hyperope, and a myope. So in a presbyope, what you can see is it's a small amount of presbyopia, but he wants to get rid of his reading glasses. And if you have access to eye trace, it gives you a lens dysfunctional index. And if it's from 0 to 10, if it's less than 5, it tells you that there is a problem there in the contrast sensitivity, the aberrations, the pupil dynamics are affected. And these are the reasons why this patient is coming back to you, and you could do well treating these eyes. And this was a patient who had a small amount of astigmatism in his eye. So we went ahead and took him on the femtocataract platform, did the astigmatic keratotomy also was done, and not going to go in great details of surgery, a gentle hydro. You can see how easily you can just separate the nuclear fragment and just engulf it at one go. It's just phacoaspiration, and the CD count is 0. So I'm not showing that, and finally he did very well. This is another way of doing it, is you need not do any softening at all. You could make 6 quadrants and then just bunch up the rexes, and then you could just do a hydrodelineation, like you can, I'm going to show you this. You could just do a hydrodelineation, and those grooves open up actually, and then you can just price apart these pieces and just engulf them, and that the surgery is done. So there's no trauma at all to the eye. You could do a flip technique, like in this particular thing. You can just inject hydro. It's very soft. It's not going to need any phacopower at all. And you just get the piece forward out of the rexes and bring it forward and just engulf it in no time, and then you go on to your cortical wash. If it is a high hyperope, like you could have done a phakic IOL, but you can't for a high hyperope, because if its AC depth is narrow and you can't do a corneal thickness is, high hyperopes, you would not do a laser procedure at all. I wouldn't do for more than a 3 diopter of hyperopia at all. So these are guys who are distressed with their thick glasses. So, but one thing you need to remember, these are high IOL parts. So because of that, there is a difficulty in predicting the effective lens position in these eyes. Again, these are short eyes. The anterior chamber depth could be normal or it could be shallow. And because the power is high, very small changes in the refractive error could cause huge refractive surprises. So in a high hyperope, you could implant a customized IOL, but you should be prepared that you're inducing spherical aberrations. Or you could put a 40 diopter lens in the bag, and the remaining power you could use as a piggyback lens. So I'm not going to go into great detail, but you should see that the incision is not too posterior, your bottle height is elevated. You should ensure there's enough cohesive viscoelastic, because there's less space in the eye, but you should not overfill the eye. You do not want too much fluctuations in the phacopower, because these can itself induce a suprachoroidal hemorrhage in these eyes. So essentially, it has to be a very careful surgery in these very small eyes. And when it comes to a piggyback lens, for every diopter, you need to, in a myope, in 1:1.5, and this for a hyperope. For a myope, if it is 1 diopter of residual error, you implant a 1 diopter of phakic IOL. But here, the patient had 6 diopter residual error, so 6:1.5, a +9 diopter of phakic IOL was implanted. So these come as a sulcoflex lens, which are large 6.5 millimeter optic lenses, which prevents any pupillary block or prevents glare. And these have undulating haptics, which sits well in the sulcus. And these have a concavity and against the convexity of the earlier lens. So there is no interlenticular opacification which can occur in these eyes. This is a case 3, which was a high myope and had a little bit of amblyopia. These are cases which I would never ever select at all. But if this person has very early cataract or has a dysfunctional lens index, if you have examined his retina, it looks normal, and he's lucky that he has a posterior vitreous detachment already. If he has a staphyloma, you should do only optical biometry and use the very latest formula like the Barrett's or the Hill RBF formula. And as far as the surgery is concerned, it's a deep AC. So if you have the latest machine, you should see that the IOP ramp is high. You should keep your IOP value should be low. You should understand that could be a retropulsion syndrome or a reverse pupillary block kind of scenario can happen. So you should keep your parameters absolutely stable. And even if the iris is to go and hit on the lens surface and cause a reverse pupillary block, you could just go in with a Sinskey hook and just lift up the iris, and that itself would break the block. So again, and the other things, you could do multiple hydrodelineations, so it's easier to emulsify the whole cataract. You should do a good PC polishing in high myopes, and you might need a CTR in these very large capsular bags if it is a toric IOL. You should do a good PC polishing in all these cases, but I would avoid an anterior capsular polishing nowadays with toric IOLs. So again, if it's a low myope, you have to be very cautious. He's happy with his ability to read without glasses, so you have to be very, very sure that he would do well with a clear lens exchange. So ideally, you have to counsel a lot. It has to be the right patient. It has to be the right choice of lens which he needs. It's beyond the content of my talk to tell you how to choose the lenses. It has to be a perfect surgery. So in that kind of a scenario, refractive lens exchange is an important segment in our cataract surgery armamentarium, and you need to be choosy and selective and do your best for these patients. Thank you.
You want to ask something? Thank you so much, ma'am. Just wanted to understand from you, we all know that RLE is not something that we normally would prefer for a high myopic, but let's just keep that out of the equation. We're talking about moderate refractive errors here.
Yeah.
Moderate hyperopia vis-a-vis a moderate myopia, and we are doing an RLE. We are choosing a trifocal. Let's talk about the power that we should choose. We know that traditionally for a cataract patient, we would choose the first plus as the residual when we're choosing a when you're choosing a trifocal IOL. But would it change if we are doing it with an RLE for a moderate myopia vis-a-vis a moderate hyperopia? Would we still like to keep the first minus in the myopic and the first plus in the hyperopic, or would you choose the same residual spherical equivalence for both of these?
No, I would first of all never do a bilateral surgery. I would
No,
do
no,
the
even
dominant eye preferably first, and make him emmetropic for distance in that eye, and go. Then it is just that we do it in a week's interval, but people are coming from outstation, we do it in 3-4 days. And then when we do, before that, we do the refraction and try to understand whether he would need a little more myopia, then we give him a little more myopia in the other eye. Even though in a trifocal, you can implant the same power in both eyes, but we make these small adjustments in the, is that the question you asked?
My question was, say it's a 22.5 diopters and
Yes.
it leaves a plus 0.21 as a spherical equivalence, is what we normally choose for a cataract patient. But for a moderate myopia vis-a-vis a moderate hyperopia, if you're doing a clear lens extraction.
I would like to leave him a little myopic if at all, rather than go onto the hyperopic side.
So that's for the myopic patient?
Yeah.
All right. And since you mentioned that you do not do bilateral surgery, which is of course the need of the hour, but I mean we all understand the importance of it. How far would you leave them? What sort of a difference between the two surgeries would you leave?
Actually,
ideally?
there are so many simple ordinary patients who come to us who get multifocal done in one eye, and I tell them to get the other eye done. They are so comfortable and they come back much later. So I don't think this, unless it's a type A kind of personality. But largely, 90% of our patients get one eye done, and when they come down after the theater to downstairs to see us, we fix the other eye right away, within a week's time, and do it off.
And if it has to be done bilaterally?
See, up to phakic IOLs we do bilaterally. Somehow bilateral we do not do in cataracts, but we have done on a second or a third day in those situations where people have traveled. But otherwise we let it be for a week for the refraction to stabilize, and it can always happen. Even if it is a monofocal, sometimes you might have rarely have overcorrected, though we feel, I'm sure all of us are feeling so happy with our results, with the kind of biometry and formulae which we have, that every patient is seeing very well. But we keep that time interval. Maybe we are too conservative maybe, but we have been doing well in our practice with that amount of conservatism.
No, but since there's nothing to judge in form of the grade of cataract, if the patient presents for an RLE bilateral,
even if it is a clear lens extraction, I mean, 3-4 days is fine. It's okay.
No, but which eye do you take up first? Do you look at ocular dominance when you're doing an RLE in a bilateral?
We do look at ocular dominance. And although there are a lot of talks, I'm sure Gaurav also was there at ESRS, where they say that ocular dominance is not exactly important at all. at all. But just like that, we go ahead and do it because, okay, we have to choose one against the other. So what are your thoughts on it? I wouldn't mind knowing.
No, I don't look at ocular dominance at all, be it a cataract patient, be it an RLE.
No, not
I
in a
don't
cataract patient.
even
in
an
a
RLE. So if I'm not looking at it, even from the cataract perspective, RLE is much easier to decide. I don't look at the dominance at all. Nowadays, I've completely stopped looking at it. Any other points from anyone? Or, ma'am, may I ask you, is this your last commitment for the day?
No.
You've still got more. Thank you so much. We'll let you off then. We'll ask you to